This is a 7-minute review of Presby's stroke alert process for emergency medicine physicians. They're separate reviews for our nurses and techs and for our neurology colleagues. It's not a comprehensive review, but the goal of this module is to review our stroke alert process, including the imaging we're doing, and emphasize our individual roles and priorities in the algorithm, highlighting areas where we can improve our efficiency. A stroke alert can be activated for any patient who presents to our emergency department with acute stroke-like symptoms within 24 hours of last known well. By initiating a stroke alert, you're activating a coordinated team effort by emergency medicine, neurology, and radiology to work in parallel towards the goal of rapid identification and treatment of patients with intracranial hemorrhage, our TPA patients, select patients with ischemic stroke who are eligible to be treated within 4.5 hours of last known well with TPA, and our thrombectomy patients. Select patients who present to our emergency department up to 24 hours from last known well with ischemic stroke due to a large vessel occlusion and are eligible for transfer to HUP for mechanical thrombectomy. In January of 2018, the DAWN and DIFFUSE 3 trials were published supporting this expansion of mechanical thrombectomy to select patients up to 24 hours from last known well. Now, although these trials did not change treatment with TPA, in our effort to simultaneously identify more thrombectomy candidates, patients have spent much more of their initial evaluation in CT, and our stroke alert process has evolved and has become more complicated. Our goal is still to complete this process in less than 45 minutes, stressing the importance of efficient teamwork. So to review, once you've activated a stroke alert or a patient has arrived as a pre-hospital stroke alert, your first job is to assess their airway and hemodynamic stability to evaluate if they can go directly to CT. Techs and nursing are going to be obtaining the patient's weight, blood glucose, and vital signs with a portable monitor, and once registration is mini-reg the patient, you should initiate the stroke alert order set. This will include labs, imaging, nursing orders, and notification to neurology. The time of onset is relevant to the treatment options, and history may only be attainable from EMS or family or friends, so on arrival, it is critical to try to confirm last known well and any collateral information. Identifying if anyone is here or is coming with the patient is very helpful. Also, a quick EPIC review can identify emergency contacts, previous stroke history, other relevant clinical information, and any IV contrast or TPA contraindications. As long as the patient is hemodynamically stable and is protecting their airway, they will go directly to CT. You should go to CT for a focused history and exam. Many of our stroke alerts are not strokes, and it's not unusual for the patient to spend the next half hour in CT. We've had seizures, ischemic limbs, and even aortic dissections, so it's imperative you assess for alternative diagnoses. Neurology will meet you in the CT scanner to assess the patient for stroke, and you can update them with what you know so far, including confirmed last known well. After the completion of the non-con CT head, you should review the images and discuss with neurology to determine if the patient is TPA eligible. It takes approximately 10 minutes for TPA delivery once ordered, so at this point, if all the information you have suggests you'll be giving TPA, ordering now saves time. When you order the alteplase and EPIC, please call pharmacy to notify them that you placed the order. You should also discuss with neurology what's pending to make the final TPA decision, so you can work together to resolve those questions. The CTA of the head and neck and CT perfusion are ordered as part of the stroke alert order set. On some cases, as you gather more information, you may find one or both of these studies are not indicated, so discuss this with neurology and cancel when appropriate. CTAs are used to identify patients with large vessel occlusion, specifically the internal carotid, proximal middle cerebral, and basilar arteries, vessels that neurointerventional may intervene on. CTAs will also identify dissections and areas of stenosis. The dynamic stroke scale is probably the best predictor of large vessel occlusions, but we know even if we use a low threshold, we will miss some. For example, using an NIH stroke scale of greater than or equal to 6 in patients with ischemic stroke, we will miss approximately 1 of 8 large vessel occlusions. So if you think the patient is having a stroke, unless they have a contraindication to IV contrast or the study is delaying administration of TPA, then they should have a CTA. So who needs a CT perfusion? CT perfusion provides important information about the hemodynamics of the brain parenchyma. In this example, the area in green on the 16 slices to the right is highlighting the area with the prolonged mean transit time, or slow or delayed perfusion. The area in purple on the 16 slices to the left is highlighting the area with significantly decreased cerebral blood flow, representing the area of the brain which is already infarcted or is destined to infarct. If there is a mismatch, a larger area of the brain with decreased perfusion but maintaining its cerebral blood flow, this represents the penumbra, or an area of brain at risk for infarcting, but at this point is salvageable. This patient has a large area of mismatch and would benefit from thrombectomy. So if the patient is having a stroke, the non-con CT is used to rule out intracranial hemorrhage. CTA is used to identify patients with large vessel occlusion, and CT perfusion could help identify which of those patients with large vessel occlusion would benefit from transfer to HUP for mechanical thrombectomy. Once imaging is complete, the patient will be transferred to their room in the emergency department. If the patient has a head bleed, our initial treatment should be to elevate the head of the bed and focus on blood pressure control and reversal of any coagulopathies. If the patient is going to be treated with TPA, treat blood pressure greater than 185/110 and confirm no intracranial hemorrhage with neuroradiology. Neurology will complete the TPA checklist, but you should be in the room at time of TPA bolus. If the patient has a large vessel occlusion, neurology will discuss with neurointerventional and discuss if the patient should be transferred. Please work with neurology utilizing PenStar to arrange a rapid transfer. In summary, the StrokeAlert activates a coordinated team effort to rapidly identify patients with intracranial hemorrhage or ischemic stroke that could benefit from treatment with TPA and/or transfer for mechanical thrombectomy. And our goal is to complete all of this in less than 45 minutes from arrival. So finally, 3 areas I want to highlight which are important to ensure an efficient process. Treatment with TPA is dependent on the time the patient was last seen well, so when the patient arrives, talk to EMS, family, or listed contacts, and try to confirm the time of last known well. Patients are in CT for a long time, frequently the majority of their first 45 minutes here, so please go to CT for your initial evaluation and early communication with neurology. And finally, while the patient is in CT, after the non-con CT is completed, discuss TPA eligibility with neurology. If all the information you have suggests you will likely be giving TPA, order TPA and work together with neurology to address any unresolved questions to make the final decision. Overall, we're doing a great job, but we're always striving for improvement. Our StrokeAlert algorithm is posted in the ED and on our website for review. Please reach out to me with any questions or suggestions. Thank you.